And today we are going to be talking about multiple sclerosis. Before we begin, there's just a few terms that we want you to know. So the first one is myelin, which is an insulating layer or sheath that forms around nerves, including those in the brain and spinal cord. It is made up of protein and fatty substances, and this allows electrical impulses to transmit quickly and efficiently along the nerve cells. The second one is neurodegenerative, which is resulting in or characterized by degeneration of the nervous system, especially the neurons in the brain. The third one is cytokines, which are a category of signaling molecules that mediate and regulate immunity, inflammation, and hematopoiesis. The fourth one is endothelial, which refers to the cells that line the interior surface of blood vessels and lymphatic vessels, forming an interface between circulating blood or lymph and the lumen and the rest of the vessel wall. Macrophages are specialized cells involved in the detection, phagocytosis, and destruction of bacteria and other harmful organisms. B cells, which are a lymphocyte not processed by the thymus gland and are responsible for producing antibodies. The last one is oligodendrocytes, which are a glial cells similar to an astrocyte, but with fewer protuberances concerned with the production of myelin and the central nervous system. Multiple sclerosis. Multiple sclerosis, also known as MS, is a chronic neurodegenerative disease that affects the central nervous system and results in neurological problems. The disease attacks myelin, causing inflammation and damage. Myelin, as we know, is necessary for the transmission of nerve impulses through the nerve fibers. Once the myelin becomes damaged, it causes delays of the transmission of these nerve impulses, and eventually the signal cannot travel. Think of it as though you have a letter that's in your mailbox and you want it to reach your friend, so the mailman is going to pick the letter up from your mailbox and drive along the road to deliver it. But let's just say something happens, like an earthquake, and destroys the road ahead of him, so now the letter can't get to where it needs to go because the road is damaged. It is the same thing with MS. You get a breakdown of myelin, which causes the action potential to travel more slowly, and in some cases, not at all. Pathology of multiple sclerosis. MS usually affects individuals between the ages of 20 and 40 and is most commonly seen in women. There is a 2-to-1 female to male ratio for this disease. The cause of this disease is still a mystery, but it is believed that a combination of environmental, immunological, and genetic factors are to blame. And another important thing to remember is that MS is like snowflakes. It affects everyone different, and no two cases will show the exact same side effects. Let's look at our client. Her name is Susan Weagle, and she's a 35-year-old female. She is married with 2 school-age children, and she works as a physiotherapist, but has been on sick leave for the past 5 months. She cries often and is very discouraged, and Susan is scared for her future. Look at this timeline, which illustrates Miss Weagle's journey with MS. It all started 10 years ago, when she was diagnosed with relapsing remitting MS, which is also known as RRMS. 8 years ago, Miss Weagle started taking interferon beta 1A injections and methotrexate injections. 5 years ago, she noticed a significant change in her neurological functions, as she often experienced heat tolerance, a tendency to fall, and a change in her vision. Just 2 months ago, she was working a lot and experienced a lot of stress. She got sick with the flu, and her neurological symptoms worsened yet again. She was unable to hold objects, she experienced tremors, she felt very exhausted, and experienced some bad falls. Ever since she noticed joint pain on the right and afterwards on the left side of her body. After a few days back to work, she developed a right hemisensory deficit. The correct diagnosis by the practitioner is secondary progressive MS. To understand this case study better, let's take a look at the pathophysiology of MS. and here's a good visual that breaks down the process step by step. So first, the T helper cells are activated by genetic or environmental factors, which we'll talk about later in the slideshow. This activation allows the T cells to squeeze past the endothelial cells and break through the basement membrane, making their way to the brain. It then attaches onto the myelin, mistaking it as a foreign object, and sets off alarms which release cytokines. Cytokines promote the breakdown of the blood-brain barrier, making it much easier for more T cells to squeeze through into the CNS. Cytokines also recruit more immune cells, including B cells and macrophages, which all of these immune cells have a negative effect on the myelin, contributing to the breakdown and also causing clusters in the CNS, which is called neuroinflammation. The brain does have a way to repair itself and begins with the oligodendrocytes, which begin the remyelation process, but over time this becomes less and less effective. Another visual of the pathophysiology of MS. Personally, I'm a very visual learner, so I want to show it in a few different ways. So first, T cells become activated due to unknown factors. Secondly, CD4 T cells make their way into the CNS and recognize myelin as foreign. Thirdly, T cells release cytokines. And fourth, just describes what cytokines do, and they have three major functions. A, they degrade the blood-brain barrier, making it more permeable. B, they recruit other immune cells. And C, cytokines have been shown to be toxic to myelin. And then we move on to fifth. So the recruited immune cells cause damage to myelin. And then the immune system does have regulatory T cells, which can slow/stop the immune system response in the CNS for short periods of time. But in those with multiple sclerosis, this does seem to weaken over time. I also thought it was cool to include a recent study that showed that patients with MS have the same number of regulatory T cells compared to those without, but they are less effective. Let's take a look at the subtypes of multiple sclerosis. So there are currently 4 subtypes, and the first one we're going to look at is relapsing remitting MS, also known as RRMS. It is the most common subtype, and it affects 85% of all MS patients. It is defined by flare-ups called relapses or exacerbations of symptoms, which are followed by periods of partial or complete remission. During remission, symptoms disappear or improve. And if you remember from Miss Weagle's case study, she was diagnosed with RRMS 10 years ago. So now let's look at secondary progressive MS. Progressive MS is Miss Weagle's current diagnosis, and it is also known as SPMS, which is categorized by progressive worsening of neurological function over time with or without periods of remission. It usually takes 10 to 20 years for RRMS patients to develop into secondary progressive MS. It follows a diagnosis of relapsing remitting MS, which makes sense in Ms. Weagle's case. Quickly going to touch on the last 2 subtypes of multiple sclerosis, which include primary progressive MS, which affects approximately 10% of patients and is characterized by gradual accumulation of disability with no relapses or remissions. This type is also much more resistant to any treatment with drugs. The last subtype is the most rare, and it is called progressive relapsing MS, which occurs in less than 5% of patients, and it is characterized by stable neurological decrease and obvious MS attacks with no periods of remission. This is another very good visual of the subtypes of MS, and I would reference this when studying, as it gives a very good description of each subtype and breaks it down very easily. This diagram shows a visual representation of the 4 subtypes of MS. The top chart is progressive relapsing multiple sclerosis, and you can see that there is a steady decline in a client's disability with superimposed attacks. The second one shows her current diagnosis, which is secondary progressive MS, and you can see that the initial relapsing remitting MS that suddenly begins to decline without periods of remission. The third one shows primary progressive MS, which is just a steady increase of disability without any imposed attacks. And the last one, which is relapsing remitting multiple sclerosis, shows unpredictable attacks which may or may not leave permanent deficits followed by remission. Another look at the subtypes of multiple sclerosis. One of the questions we were asked to look into is whether we agree with Ms. Weagle's current diagnosis of secondary progressive MS. And after looking at the characteristics of each subtype, we concluded that yes, we do agree, and for the following reasons. Ms. Weagle was diagnosed with secondary progressive MS following a diagnosis of RRMS, which she has had for 10 years. And her neurological function is progressively declining, and that checks off all of the characteristics of secondary progressive MS.
The epidemiology of MS. Approximately 2.5 million people are affected in the world. The incidence is 1 in 750 to 1,000, and the prevalence increases in areas further north or south from the equator. And this is due to a decrease in sun exposure, a low dose of vitamin D. And this is more common in areas of Scotland, Northern Europe. And as you look at this image right here, there's high risk in areas like Canada, Russia, Europe, and New Zealand. And research suggests that high levels of vitamin D levels are associated with a reduced MS risk. And there's also a relationship between MS and the location of birth. For example, if the person travels to MS high risk regions before 15 years old, so before puberty, may predispose a person to develop MS later on in life than the same person who traveled after 15. There is no single risk factor for MS, but several risk factors are believed to contribute to the overall risk. These include environmental, immunological, and genetic factors. So, with environmental factors, you can have pollution, smoking. So, smoking increases the risk. However, if you stop smoking before or after the onset of MS, it can help delay the disability progression. Also, microbial infection increases the incidence of MS, and MS can be induced by many microbes. And also, viral infection, which is the presence of oncoloidal bands in the CNS fluid in MS patients, and also Epstein's Barr virus as well. Also, genetic factors can play a role with MS. So, the HLA-DRB1 is the strongest genetic factor linked to MS. It increases the MS risk by threefold, and this is due to changes within the chromosome 6. Also, identical twin with MS increases the risk by 30%, and if parents have MS, the development increases. And also, immunological factors are an abnormal immune mediated response causes inflammation and damage to the myelin in the central nervous system. Symptoms vary from person to person. So here I list the various symptoms associated with MS. The ones in bold with the star are the ones that Susan is experiencing. So I will go into further detail on the symptoms that Susan is experiencing. So the first one she's experiencing is numbness, tingling, which is the most common sensory symptom with MS. Also weakness. So weakness occurs due to the delay of messages within the spinal cord from the damaged nerves, and this makes it harder for muscle movement. Also, you can experience tremor as well. And vision problems can occur. So vision problems is one of the early signs, which is it's a common symptom of RRMS type. And vision problems occur in MS patients when the optic nerve becomes inflamed and damaged. This is called optic neuritis. And this is the optic nerve is unable to send signals to the brain, and this can result in double vision, blurred vision, vision loss in one eye, and this usually resolves within a few weeks. Also, patients can experiencing difficulty walking, so that's what Susan is experiencing as well. And this could be from factors such as weakness, balance, and fatigue. Also, you can experience balance and dizziness. So Susan has balance problems and sometimes a sense of spinning. This results from lesions in areas that coordinate and maintain equilibrium and increases the risk for falls. Also, difficulty swallowing is also a symptom with MS, and Susan tends to aspirate liquids and solids. Bladder dysfunction is also a common symptom. So, with bladder dysfunction, the demyelination of the neural circuitry that's responsible for urine storage and release can result in a variety of bladder symptoms. So, these symptoms can include urine urgency, incontinence, and frequency. Also, fatigue is one of the most common symptoms with MS. It affects 80% of those with MS. And this is due to damaged areas in the brain caused by MS. It requires the body to use more energy to operate, which results in a buildup of fatigue. Also, ataxia is damage to the cerebellum that controls muscle coordination, and this could include like poor coordination and a tendency to fall. And Susan is experiencing a tendency to fall. Also, hearing loss and heat intolerance. So, heat and humidity can temporarily worsen symptoms of MS. Heat causes the nerves to conduct signals less effectively, and your symptoms may worsen with climate change. So, usually, patients who have MS they sometimes avoid hot baths, showers, and hot tubs, and also heated swimming pools. Also, cognitive changes can occur, so this correlates with the lesions on the brain. So, with memory, attention, and concentration, and Susan is experiencing short term memory. And also, emotional changes can occur, so depression is a big one, also, grief and fear. Susan is experiencing emotional changes as she's been crying a lot and it's been feeling discouraged. And so, with the laboratory findings, all the lab values are within the normal range except for the CL, which is slightly elevated, but it's nothing to be concerned about. Also, protein levels can be higher if the patient is going through MS relapse. And I also found that blood and urine tests are non specific and unremarkable in patients with MS. So, MRI is the most common imaging test used for MS. MRI plays an important role for the prognosis of disease, development, and the monitoring of disease progression. So, MRI reveals lesions in the white matter in the brain near the ventricles and shows changes within the cortex, brainstem, and spinal cord. These lesions are all demonstrated within three different imaging planes known as sagittal, axial, and coronal. Also, with MRI, they use a contrast dye called gadolinium, which provides useful information regarding new lesion activities, as the dyes will leak out the brain and reveal abnormalities. And so, when there is active inflammation, the dye can enter the blood-brain barrier since the barrier is disrupted, and the dye will highlight the inflamed areas. Also, the myelin is composed of fat. However, when the myelin has been damaged by MS, the fat is removed. Since the fat is removed, the areas contain more water and appear on MRI images as a bright spot or darkened areas depending on the type of MRI scan. So, with the first one is T1 weighted images, in that those appear isotense to hypertense, so dark areas, and the areas of information appear as active lesions, and hypointense indicate areas of permanent nerve damage. So this first image here shows the different areas that are hypointense, and they're known as black holes. And then the T2 weighted images appear hyperintense, so more bright, and they provide information about disease burden or lesion overload or lesion load. So here you can see it's an axial T2 weighted image, and it shows the bright areas here within the brain. And then there's also another one that they use called FLAIR, which is known as fluid attenuated inversion recovery, and it identifies brain lesions associated with MS, and they improve MS plaque detection by suppressing the CSF signal near the spinal cord. So here you can see a sagittal flare image, which is showing the Dawson fingers, which is a common characteristic on MRI for MS patients, and they're shown here as hyperintense areas. So Susan did have an MRI done, and it revealed multiple focal plaques in the perivascular white matter, cerebellum, and spinal cord. So here I just showed some images that may be similar to what the findings were to Susan. So as you can see here, um, the perivascular spaces are lined with lesions, so plaques. You can see within the arrows and within the perivascular um, regions. And then also, this is a lesion within the cerebellum. This is post contrast, so after they use the dye. And that's on a chrono image. And then also you can see here on a sagittal T2 weighted imaging is a hyperintense lesion within the spinal cord as well. Also, there is a lumbar puncture procedure that is also used. So this is used to remove and evaluate CSF via a needle. So the needle is inserted in the lower lumbar region of the spine, and it can help to see if the body's immune system is attacking itself, and it reveals signs of inflammation and immune system activity within and around the brain and spinal cord. So the fluid is analyzed for white blood cells, neurofilaments, and oleocolonial bands. So with the white blood cells, so if the patient has MS, the number of white blood cells in their CSF will be approximately 7 times higher than normal. And with neurofilaments, if neurofilaments are found in the CSF, this indicates that the myelin is under attack. And with the colonial bands, their antibodies from the immune system cross the blood-brain barrier and attack the myelin surrounding nerves. And with this, if you have a presence of one band, that's known as monoclonal, and that means the CSF is normal. However, if there's two or more bands, it's known as oleocolonial, which shows the presence of disease activity, and this occurs in approximately 80 to 95% of MS patients, and it will show inflammation within the central nervous system. So Susan's findings were that their fluid was clear and colorless, and this is common for MS patients. Also, mild lymphocytosis is common for MS patients, and elevated IgG concentration is associated with MS. And elevated myelin-based protein levels indicates the myelin is actively breaking down. And her glucose and protein levels are 60 mgs over DL. So if the protein levels were above like 100, then another diagnosis other than MS would be considered. There's also a test called visual invoked response testing, and that is performed by flashing a checkerboard image in front of the patient. So it takes a measurement of the electrical signal recorded at the scope over the occipital cortex. And Susan had one of these tests done, and it revealed an abnormal with slow conduction in the optic nerves. So this down here is the image of the graph of a normal response testing versus an abnormal response testing.
Take a look to see what Susan wants to know. So Susan is very overwhelmed and she wants to know what her treatment options are and what her resources are. She is also very interested in learning more about magnetic therapy, reflexology, the cannabis oil, which she has heard from her friends will help with her sleep. She also wants to know more about increased vitamin D intake and liberation therapy. The last thing she wants to gain from this is she wants to know what supports are available to help her and to assist with her daily living and mobility. More into this stuff on Thursday in our tutorial, and I also just want to remind everybody to take a look at the videos that we uploaded for the pre-tutorial material, as the video will help understand the pathophysiology of MS a lot better. Look forward to seeing you all on Thursday.